think we'll move on to the next case, which is How Far is Too Far, from Dr. Ilango, MIOT Hospitals.
Respected teachers, respected chair, and my dear friends, I bring greetings from MIOT Hospital, Chennai. Today we're going to share a story of a 54-year-old gentleman who presented to us with complaints of constipation for a period of a month with bleeding PR. He had no comorbidities. He didn't have any surgeries in the past, and his clinical examination, general examination was unremarkable. His liver was palpable, and digital rectal examination showed an ultra-proliferative lesion at 3 o'clock position, and it was 4 centimeters from the anal verge, and it was not fixed. On regular investigations, actually he went to a different hospital, so they thought it was a rectal lesion. So they did a serum CEA first, and then other investigations were unremarkable. They subjected him to a colonoscopy, probably a sigmoidoscopy. They passed up to 60 centimeters. They took a biopsy. The lesion was around 3.2 centimeters from the anal verge. While waiting for the biopsy, they subjected the patient to a CT scan, which confirmed a lesion, probably infiltrating the muscularis propria and just extending into the subserosal area. And there was some nodes around it, and the lesion was around 3.2 centimeters from the anal verge. And liver showed multiple metastases on both lobes of the liver. So a clinical diagnosis of stage 4 rectal cancer was made, and at that time the biopsy was still pending. When the biopsy results came, it was probably they needed immunohistochemistry. The routine testing showed probably an atypical neuroendocrine tumor or an adenoCA, and IHC was atypical neuroendocrine tumor. This was grade 2, and it had a Ka67 index of 2 to 3%. His chromogranin was 210 at that time. It was in March. So we subjected this patient first to whole body PET. PET showed the lesions were not PET away, but we could see the lesions in both right and left lobes of the liver. It was bilobar. And we did a whole body gallium-68 scan. It's a Dotonac scan. So it showed well-avid distal rectal lesion and also bilobar liver metastasis. So this is just a comparison of the DOTA PET and the FDG PET. You could see lesions in the DOTA PET while FDG is not avid. So it was consistent with somatostatin receptor expressing tumor. It was a stage 4 cancer. This was the time the patient presented to us. So we had a multidisciplinary team of surgeons, our hepatologist, and a nuclear physician, along with our medical oncologist. We decided to subject this patient to PRRT, which is peptide receptor radionuclide therapy, using lutetium-177. Lutetium, as you know, is a beta and gamma emitting radionuclide. Its maximum penetration is 2 mm, and it has an half-life of 160 hours. We planned for a protocol, and this protocol included 4 cycles of lutetium therapy, and we planned to reassess the patient after 2 cycles. The first cycle, initially lutetium was given, and after a week interval, we gave the patient injection sandostatin. Each dose is for a month, so after 2 months, we subjected the patient for second cycle. So after second cycle, the patient started having increasing bleeding PR. So we thought maybe it is progressing, so we wanted to do an interval assessment. The chromogranin A was dropping. However, the primary lesion was not reducing in size. In fact, it was increasing in size. However, the you can see the lutetium scan. After 2 cycles of lutetium, in the Totonac scan, the liver secondaries were reducing in size. So the patient had a non-responding primary lesion and good response in liver secondaries. So, and also she was having bleeding PR. So we had to do a remove the primary. We did an ultra-low anterior resection with coloanal anastomosis with a covering ileostomy. And the indication was no response to the primary for PRRT. And he had an uneventful post-op recovery except for a brief period of AF which was managed medically. So the biopsy was the same. It was consistent with grade 2 neuroendocrine tumor and margins were negative. So after a cooling period of 1 month, we gave 2 more cycles of PRRT and we reassessed them after 4 cycles. So this is the MIOT scan, PET scan, Totonac PET scan. So you can see the lesions have come down in size considerably and there is no uptake in the primary area. This is just a comparative scans of before therapy where you can see the size of the liver secondaries when comparing after 2 cycles and after 4 cycles. There is a considerable reduction in size and the main reason why PRRT was considered even in the first instance was the large tumors wetting the middle hepatic veins. So, and also there was a lesion on segment 4. So if you could subject him to primary surgery, then we would have taken out most of these, the right lobe along with segment 4. So we wouldn't have enough remnant for a survival. So we planned for the final surgery. The final surgery was planned to be a right hepatectomy and ileostomy closure. And since it was somatostatin receptor expressing tumor, we planned to do what is called a radio-guided surgery. This radio-guided surgery is done by injecting Hynitoc the previous day. So this is usually done the previous afternoon. So, and then we do what is called a Hynitoc scan. And in this Hynitoc scan, we can estimate the lesions. This is the normal kidney uptake. Now we can see the liver coming. And on the left you see the spleen and you can see the metastasis now. There is one in segment 4, the rest of them are in the right side of the liver. The concept is when you inject Hynitoc 12 hours before surgery, the tumors will take the Hynitoc and they will not excrete it, but the normal liver, the background liver, will excrete the Hynitoc. So if you operate after 12 hours with a gamma probe, you can identify tumors that are in the remnant liver. So we did a right hepatectomy, we excised the segment 4 lesion too, and this is the remnant. And after excising, it is a very sensitive probe. So if you have a large tumor on the right side, and if you're going to screen the remnant, it's going to be false positive. So we have to remove the primary tumor, and we need to do what is called a assessment of the dose. What is the radiation? So the radiation is assessed here. So this is on the specimen side where there is a tumor. It's around 180. Here the assessment is done on the remnant side. This is the cut surface. I'm sorry, this is upside down. The radiation levels is low here. It's around 70 to 80, and you can see the assessment is done now on the spleen. So in spleen it's around 27 to 30. You know about neuroendocrine tumors. These have a different presentation. It's a spectrum of disease. Some are indolent, some are very aggressive, and metastasis at the time of diagnosis is not infrequent. And this is seer data. You can see all of the malignant neoplasms have been constant. The incidence has been constant throughout the period of 20 years, 50 years, sorry. However, the incidence of diagnosis of neuroendocrine tumors has been increasing. Generally, the grading is done based on Ki-67 index. The low grade meaning it's Ki-67 index of less than 2%, while if it's more than 20, it is classified as high grade. The prognosis also depends upon the site of origin of the neuroendocrine tumor, and even whatever may be the site, the grade determines the prognosis. So the higher the grade, the poorer is the prognosis. They behave very aggressively. And what we have noted is when you do both Dotanac scan and FDG PET, if they are avid, that is Dotanac avid, they are well differentiated because they express somatostatin receptors, while if they are FDG PET avid, they don't express somatostatin receptors and they behave very aggressively, and these does not respond to somatostatin analogs or radionuclide therapy. They respond only to chemotherapy, that too very partially. Our whole protocol was based on this trial. This is a phase 3 trial, NETR trial, where it was done in 41 centers in 8 countries. A group of 200 and odd patients were randomized to 2 groups, 116 in lutetium dotatate group with somatostatin analog, and the rest were the control group. They were given double dose somatostatin, and the response was with the PRRT group is around 65. This is PFS, progression-free survival was 65.2%, and while in the conventional group it was only 10.8%. And response rate was 18% in the lutetium group, while it was 3% in the conventional arm. You can see a difference in PFS, and all other trials have been conducted before. None has included lutetium, and this is the first time where they have compared lutetium and octreotide. To conclude, respected chair, ladies and gentlemen, DOTA-PET has a higher accuracy than conventional imaging in diagnosis and staging of NET, and now it's been included in NCCN recommendations. And FDG-PET at baseline has a strong prognostic value in patient survival to assess patient survival, and use of PRRT with lutetium now has been approved by FDA, improves progression-free survival. And use of radio-guided surgery is an usual adjunct in surgical management of well-differentiated neuroendocrine tumors, and multidisciplinary approach offers better outcome and survival in patients with metastatic neuroendocrine tumors. Thank you.
That was a very good presentation. Just want to know, how is the patient now?
The patient is doing well.
Doing well. Are you planning any additional therapy?
No, ma'am. Actually, we are going to assess him now. So it's time now. So we've been, maybe next week we'll do again a PET scan. It will be a next scan. So if there is additional lesion, then we need to address it at that time. So at least during the surgery, we didn't find any additional lesions. So we have a series of patients now. This is the first one we have completed surgical therapy. So some are responding, some are not. We are also in the process of assessing the
liver transplant?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. The gamma probe is usually they use so oncologists use for the sentinel nodes. So it's never been used in surgery like this. So it's just an suggestion.
You can take it to the care.
Yes, sir. Yes, sir. It can be pushed and taken.
Liver transplant would be an option?
Yes, sir. Actually, the spectrum is divided into 3. One is easily resectable lesions. For unresectable lesions, we generally suggest liver transplantation. And the most important thing in these patients who undergo liver transplantation is the grade of the tumor. So you need a biopsy, and if the Ki-67 index is less than 20%, so these patients do well. There is a recent Hungarian trial. They've done 10 transplants, and they found that if the lesions are confined, they have a lesser Ki-67 index of less than 20, and if the primary is ileum or they do very well. Non-pancreatic NETs do very well after transplantation.
Smart. You have got any statistics, PRRT, how many people improved with that, and you have got
Yes, sir.
any case series?
No, we have a
Any published data?
No, so published data is the NETA trial.
I see.
So they have not actually NETA trial was done in 41 centers in 8 countries, and they randomized 200 odd patients. One group was PRRT, and all these patients in general who were included in the study were patients who already failed somatostatin. So they had a biopsy, they had a proven well-differentiated endocrine tumors which are not resectable, and they underwent PRRT. They were classified, they were randomized into 2 arms. One was PRRT with double dose sandostatin, and another was just double dose sandostatin. So they found significant 63% progression-free survival in first group patients. That's one required PRRT. This is the first trial actually. PRRT was the first trial. So before that it was not very frequently used. And this therapy, the most important thing is when you counsel patients on this therapy, you should tell them the side effects. So apart from myelosuppression, which can happen in 2% of severe myelosuppression, clinically significant myelosuppression can happen in 2% of patients. And our patient, obviously it was a single patient, we didn't have any issues, but in the NETA trial, in around 10% of patients had severe myelosuppression.
More number of cases of neuroendocrine tumor being diagnosed nowadays. Many of the medical colleges said we don't used to see that. It is because of the advent of rotavirus scan. Because rotavirus scan is revolutionary because you will be able to diagnose it much earlier. Because neuroendocrine is such a rarity in those days, only 5 years ago. Yes, ISC and rotavirus scan.
Did you suggest that liver transplantation is one of the options?
Yes, sir.
I have 2 doubts on that. One, quite often we're not sure where the primary is. Secondly, the transplanted liver, does it also develop a tumor?
Sir, if you are going to, actually it was, the transplantation for neuroendocrine metastasis was suggested in the 90s. When they started transplanting all patients with neuroendocrine metastasis, they didn't have Dodolac. So the idea was whatever dye they used at that time was concentrating where there was more tumor. So obviously the more tumor was in the liver and the primary was already missed. So they did a transplant and primary was still there. So these patients developed secondaries again in the transplanted liver. So after some period this interest weaned off, that most people didn't want to do transplant for neuroendocrine metastasis. But now we are able to differentiate which patients will benefit and which may not. So if you have a patient who is irresectable and you have a well differentiated pathology, and these patients do very well after transplantation.
The requirement is not to know where the primary is.
No, sir, you can, it is.
Those days, the identical scan was not nowadays we have this identical scan, so you look at the primary even if it is very small. We have now an 18-year-old girl who was not a lesion, a small, about half a centimeter lesion in the ileum and multiple liver secondaries. We had given 6 PRRTs, it is not responding. So we are planning to resect the primary tumor and do a liver transplant. In fact, we have advised liver transplant for her and we have registered for a liver transplant. It is one of the treatment available.
Once you remove the primary, won't the secondary shrink?
No, sir, it doesn't shrink.
And
Especially
I
if
think,
it doesn't respond to PRRT, that means it's probably it won't respond to any other treatment, but for surgery.